Good evening, everyone. Today's topic is hematological management, and the faculty that we have here is Dr. Shraddha Patharkar, ma'am. She is the associate consultant at ABMH Pune. Thank you, ma'am. You can start.
Yeah. So we have covered majority of hematological topics. So the only two topics were remaining, out of which one will be actually included in oncological emergencies. But I'm covering it today because I have only two topics today. Rest two topics in hematology like leukostasis and hyperviscosity syndrome. Again, those become a part of oncological hematological emergencies. So I have not covered those, but I'll just tell you the salient points that you need to read about. So and I have only two questions, but through theory, what kind of questions they might ask you in the exams, I can just uh, will put focus on those things. So we'll start with the first case. 22-year-old female got admitted with fever, cough with expectoration, breathlessness. She got treated for severe community acquired pneumonia in critical care. Despite cultures getting negative and repeat cultures didn't find any organism, she continued to spike fever and organ dysfunction persisted. Her CBC showed persistent leukopenia and thrombocytopenia. So dengue malaria panel was sent, which was negative. Imaging done for source identification. CT chest, there was resolving pneumonia patch as compared to the previous scan, and CT abdo-pelvis showed hepatosplenomegaly. Hemat reference was given for her persistent bicytopenia. Uh, uh, the hemat team did bone marrow study on the patient, and hypercellularity with the hemophagocytes was the finding. Which of the following is true statement regarding this case? Macrophage activation syndrome is HLH in rheumatological disease. We call it as HLH in rheumatological disease. We call it as a macrophage activation syndrome. Malignancy associated HLH has the worst prognosis. H score is used in adults to diagnose HLH. Uh, Steroids or immunosuppressants is the mainstay of the treatment, and HLH mimics septic shock with multi-organ dysfunction, as in our case, and all are true. Can anybody tell me the which of the following is a true statement out of six?
All are true.
Yes, all are true. Uh, See, because we know this is the hematological domain, but you cannot diagnose HLS in your first uh, patient's impression. So they pertaining to our case, it looks like septic shock with multi-organ dysfunction, and we are not able to find out the source of infection. So despite patient getting treated for underlying infection or sepsis, and the fever is not settling down, or sometimes when patient presents with fever of unknown origin and presents with bicytopenia, hepatosplenomegaly, all these clinical points as well as some lab features will point out it might be HLH. So there are HLH mimics, septic shock is one of them. So you have to keep that in mind. So what is HLH? It is a fatal disorder characterized by dysregulated activation of cytotoxic T lymphocytes, natural killer cells, and macrophages. So all these immune cells, they get activated, they produce hypercytokinic response, and there will be, because there's cytokine storm like picture, like in COVID patients, the way we used to get cytokine storm, that storm is mounted, and then immune mediated injury to multi organ happens. So it's HLH is a it's an emergency situation, and it's a if not treated, it has a poor prognosis. Diagnosis is difficult because of its diverse manifestations and the clinical presentation, and there are many diagnostic mimics. just now told you that septic shock, or sometimes liver dysfunction, because here the liver enzymes will be deranged. Many a times dengue shock syndrome, uh, they may develop HLH, or dengue shock syndrome itself can mimic like HLH. So there are many instances where you cannot differentiate between the infection and the HLH. Recognition of hemophagocytic histocytes is the key component of diagnosis, but again, it's not the specific criteria. HLH 2004 protocol used for pediatric population, also used in adults, but it's not validated. So we, for adult diagnosis of HLH, we use HS score. So that is a online uh, web scoring system. It has 9 parameters which predict whether patient has HLH or not. So which are these 9 parameters? The presence of immunosuppression, fever, organomegaly, either hepatosplenomegaly, elevation in triglycerides, ferritin levels, AST, ALT levels will be elevated, more of a ALT, and fibrinogen levels will be low, presence of cytopenias, so at least 2 cell lines will be suppressed, and hemophagocytosis in the bone marrow. So there are these 9 components. You put numbers, and each criteria is assigned some value, and a higher score corresponds to higher probability of HLH. So, and the cutoff to diagnose, optimal cutoff is 169. So this is the online web calculator that is available, and we use this for adult HLH diagnosis. So what is primary HLH and what is secondary HLH? So primary is familial. It is because of some your genetic mutations affecting your this cytotoxic T cells and NK cells. So mostly they present early in life, most within first year of life, and they are dreadful. I mean, the prognosis is much worse, and they, because it's a primary, associated many immunodeficiency disorders are also there. But in adult, what we get is secondary HLH, and most common cause for the secondary HLH is infections. Second most common is malignancies. Hematological malignancies lead to HLH more than the solid organ or any other non-hematological malignancies. Rheumatological disorders, many autoimmune disorders, drug hypersensitivity reaction, this DRESS syndrome, uh, then hematopoietic stem cell transplant, graft versus host disease reaction. So all of these can lead to secondary HLH, and the treatment of HLH is immunosuppression, because now this your immune system is hyperactivated or dysregulated. So you need to suppress this immune system. That is the mainstay of the treatment. And incidence is not that uncommon. It's 1 in every 2000 adult patients admitting to the tertiary care hospital. So you have to keep this in mind to rule out HLH when your patient is not getting better and your patient's fever is persistent and cell lines are suppressed. So you have to think about this. Then EBV associated familial HLH is also there. In secondary HLH, it's when many a times when patient is on chemotherapy or some immunosuppressants, and this EBV reactivation might happen, and that can cause HLH. Cytokine storm of HLH mimics COVID-19 infection. Most common cause, again, uh, in Indian setting, it's infection, but second most common being malignancy, and is associated with malignancy associated HLH has a worse prognosis because it has a very rapidly deteriorating course and high mortality rates. HLH associated with rheumatological disorders, connective tissue disorders, we call it as a macrophage activation syndrome. So that term, macrophage activation syndrome, is HLH in rheumatological conditions. It's not for non-rheumatological HLH. So HLH responding to immunosuppressive treatment, we call it as HLH disease. But when despite giving immunosuppressants, it's not getting better, then you have to label it as a HLH mimics. Clinical presentation, typically patient will have a high grade fever. 100 most of the times, more than 98 to 99% of the times, HLH patients have a high grade fever more than 38.5. If not, then you have to question your diagnosis. But there are confounders. Maybe you are giving antipyretics, maybe patient is on ECMO or CRT ongoing, where there will be heat loss. So Apart from those cases, most of the cases will have high grade fever or non resolving fever. Cytopenias, again, in three lines out of three lines, thrombocytopenia is the first one to you might notice. Again, sepsis causes thrombocytopenia, so here whether it is HLH related or sepsis related, it's difficult to tell. Multi-organ involvement, when it may present as a ARDS lung. In heart, it may present as a myocarditis, reduced EF. uh, in kidney dysfunction, AKI. In CNS, patient may present as a delirium, delirious, focal neurodeficit, uh, posterior reversive hypertensive response, and press like features, seizures. In liver, it may present as just transaminitis, or may present as a fulminant liver failure as well. So HLH, dengue shock syndrome with HLH can present as fulminant liver failure. Then cytopenias, coagulopathy. Even these patients can present as a DIC, rash, petagy because of thrombocytopenia, organomegaly. Lymphadenopathy is not that common. If there is like multiple mediastinal or abdominal lymph node enlargement, you have there is a possibility of some other diseases rather than HLH. Then you have to rule out TB, histoplasmosis, lymphomas, because again these are also mimics. But again, lymphadenopathy is not very common with HLH. It's common with the chronic granulomatous diseases or some other lymphomas and all. So characteristic microscopic finding of HLH is, you'll get this hemophagocytes, but it's again not very specific. And these infiltrates, they may be seen in some other, like not always you need to do bone marrow study. Maybe this hemophagocytosis might be noted when you do biopsy of spleen, liver, lymph nodes, or some other sites like lungs, meninges. But again, many a times this patient have severe thrombocytopenia, so taking biopsy from these other sites is risky. And it's better to go for a bone marrow biopsy, because again, even with low platelets of 20,000, there is no need to transfuse. You can get bone marrow biopsy done at such low platelets. Infectious causes of HLH, they also increase your plasma cells, immunoblast, granulomas, and you can notice that also in bone marrow. So by doing bone marrow, you can rule out other infections and some other lymphomas or some myeloproliferative disorders sometimes, if you think they are mimicking your HLH like picture. um, Again, lab diagnostic criteria, serum ferritin is having it's very important. It has a negative predictive value, and the cutoff being 500. So your serum ferritin value, if less than 500 nanogram per ml, then it, according to HLH 2004 criteria, you can rule out HLH. But again, to diagnose HLH, I will show you the table, next table. You need at least 5 out of 8 criterias. So it's not just the single ferritin value will not diagnose it, but definitely it has a negative predictive value. uh, and most of the times in HLH, you have ferritin levels there, those are special in adults, they are quite high, even about 10,000 many a times. And higher the value, more is the sensitivity and specificity to diagnose HLH. And again, it in higher the value, it indicates poor outcome. So again, a high ferritin level, high hyperfibrinolysis with a high D dimer, drop in fibrinogen, prolonged PTINR. Again, lab wise hyperfibrinolysis, again this picture mimics like a DIC. So HLH may present as a DIC also. Activated lymphocyte release the soluble form of CD25. So here, because of this dysregulated response, your lymphocytes are activated and they will release this CD25. But again, this test is not available everywhere, and it takes some time for the report to come. So but again, it's relatively specific to diagnose HLH, a soluble CD25, raised soluble CD25. So this is your diagnostic criteria of HLH. Out of 8, 5 should be present. So fever more than 38.3, splenomegaly, cytopenias affecting at least 2 of the 3 cell lines, like hemoglobin of less than 9, platelets of less than 1 lakh, neutrophils of less than 1000, uh, hypertriglyceridemia more than 265 milligram per dl, sorry, low fibrinogen levels less than equal to 150, hemophagocytes in bone marrow or spleen or lymph node or liver biopsy, low or absent NK cell activity, ferritin levels more than equal to 500 nanogram per ml, and soluble CD25 which is raised. So out of these eight, five should be there to diagnose it as a HLH according to HLH 2004 diagnostic criteria. But for adult, I have already mentioned this was actually designed for pediatric population, and we are still using for adult. But again, it's not very much validated, and we calculate HS score, which is an online web score, and that cutoff is 169. You have these 9 parameters. You put numbers in that, and if your number comes as more than 169, you can label it as a HLH. So again, I've already mentioned about this. In adult we have secondary HLH, infection associated, again, in any like bacterial, viral, parasitic, fungal infection can cause infection associated HLH. And why you need to know whether it is infection associated malignancy, not only for prognostication, like I have already mentioned, malignancy associated HLH has a poor prognosis because of rapid deterioration, but your treatment also differs somehow. For autoimmune diseases, like you need pulse steroid and cyclophosphamide maybe, and there are like interleukin antagonists for infection related, that we will see in subsequent slides. So you need to differentiate whether it is infection related, malignancy related, autoimmune disease related, transplant associated. Many a times it's graft versus host disease patient, uh, spiking fever, not getting better, persistent bicytopenia, you have to suspect HLH. Then drug associated, many hypersensitivity reactions, many cancer immunotherapy agents, drugs causing DRESS syndrome, they also cause HLH. So again, the commonest findings, as I have already mentioned, if there is no fever, it rules out, provided you are ruling out confounders like patient has received antipyretics, you are doing cooling measures, and that's why now there is no temperature, or maybe patient on ECMO or RRT, and that's why there is no patient is not spiking fever. But otherwise, 100% of the times there will be fever. Splenomegaly will be present in adults in 40 to 80% of the cases, hepatomegaly in 14 to 70%, uh, neurological symptoms 9 to 25%. But again, when the patient uh, of HLH involves brain, like neurological symptoms, when he develops, you have to aggressively treat with the etoposide, not just the steroid. Dexa you can give, but uh, etoposide, which is actually a salvage treatment, many a times we use for the refractory HLH. But once the CNS is involved, the mortality is quite high. So you have to start early etoposide. That thing you need to remember. And miscellaneous, like maybe rashes, lymphadenopathy, lung involvement. But again, the commonest present findings will be fever, splenomegaly, hepatomegaly. So, in labs, commonest finding will be cytopenias. More than two lines will be abnormal. Maybe anemia, thrombocytopenia, leukopenia is less common. Mostly, it is anemia and thrombocytopenia in more than 85% of the cases. And triglycerides will be high in 22 to 88% cases. Fibrinogen will be low. Ferritin levels more than 500, it's there in 77 to 100%. So after cytopenias, commonest finding will be high ferritin level, which has a very high negative predictive value, because ferritin in sepsis also you'll get high ferritin level if patient is having dengue hemorrhagic shock syndrome, fulminant hepatic failure, or maybe patient has received multiple transfusions. So ferritin is not specific for HLH, but it has a negative predictive value. You can rule out when the value is less than 500. Elevated soluble CD25, again it's very specific, but it's like not available, or maybe uh, not test is not available everywhere. So hypoalbuminemia and abnormal renal function, elevated transaminases, again elevated ALT, AST, hemophagocytosis, and low absent NK cells. So these are like lab findings. And so what, whenever such patients, when you are suspecting HLH, what battery of investigations you need to get done is routine all blood tests that you do in any sepsis patients that you'll do. And for source control, anyways, you'll get your CT chest, abdo, pelvis. uh, at the same time, it helps you know about organomegaly or occult infection, as well as malignancy, if any. So you get CT chest, abdo, pelvis done. Then HIV serology, serology of EBV, CMV, viral etiology of HLH, HBV, HCV, PCR for EBV, CMV, HSV, VZV, nasopharyngeal PCR for COVID, influenza. If, like in our case, patient presented with pneumonia-like symptoms. So if patient maybe because of some immunosuppressants, or maybe on steroid therapy, or hematological underlying malignancy, you have to send consider fungal infections as well, maybe post transplant status. So serum 13 BDG you have to send. Evaluation for the additional infections. So according to the site of infection, according to the clinical presentation, whether it is parasitic, whether it is tropical infection, you have to send accordingly. And sometimes even the connective tissue disorders present as a multi-organ involvement, multi-system disease with fever. So again, it's, they mimic like sepsis. So you have to, in autoimmune disorder, like in such cases, you have to send ANA by IFA and ANA blot. So again, I've already mentioned the HLH mimics. So liver disease, catastrophic antiphospholipid antibody syndrome, because again it's a multi-system involvement in that those cases. Septic shock, drug rash with eosinophilia, and systemic symptoms like hypersensitivity, drug reactions, flare of rheumatological diseases, tick-borne illnesses. They mimic like HLH. If your immunosuppressants is helping your condition to get better, then you label it as HLH disease. If not, then they are HLH mimics, one of these. Again, because HLH and sepsis, they mimic very closely, you need to, all sepsis patients, when not getting better, please think about HLH. In both the conditions, your CRP and PCT will be elevated. uh, HLH may be trigger complicated by sepsis, and HLH and sepsis, they may coexist also. HLH must be considered in patients with sepsis who do not respond to conventional therapy with antimicrobials and supportive measures. Maybe you have given all broad spectrum empirical proper antibiotic in the proper dosages, and still your patient is not getting better. Or maybe your patient got better, but the fever is not subsiding, and there is a persistent bicytopenia and high ferritin levels. In all these cases, you have to if the patient has like splenomegaly, persistently low fibrinogen, high D dimer, high ferritin, DIC like picture, then elevated triglycerides, then you have to think about HLH. Many atypical infections, because of visceral leishmaniasis, atypical infections, TB, mycobacteria, histoplasmosis, Bartonella, Brucella, adenoviruses, disseminated herpes virus, they lead to cytopenias, pancytopenia, bicytopenia, and elevation of these inflammatory markers, maybe ferritin and D dimer, everything, and they present like a HLH like picture. But again, this intracellular infections, maybe mycoplasma, leishmania, TB, the treatment here is because these infection causing HLH, or maybe they mimic like HLH, but you have to treat the underlying cause. If you are getting gene expert TB positive, you have to start AKT. So you target the treatment of that underlying etiology first. In most of these cases, the etiology is not immune related, so by giving steroids or giving immunosuppressants will not help when it is the atypical infections. So you have to treat atypical infections and not with the immunosuppressants. Then this dress syndrome, drug reaction with eosinophil and systemic symptoms, they present as HLH but should be managed with discontinuing the offending drug. and then you can supplement them with those steroids if patient is not improving. So there are certain changes here. If there is a intracellular infections or typical infections, you have to treat those infections, not with the steroids and immunosuppressants as like our HLH, other causes for HLH. And Rett syndrome, you have to remove the offending drug. So, coming to the treatment part, of course, the underlying whatever the precipitating cause that you have to treat, whether it is infection, then antibiotics, antifungals, antivirals that you have to start. Rituximab may reduce viral load if it is EBV related HLH, and uh, again, it's if malignancy, then you have to consider chemotherapy, combination chemotherapy if needed. If it's a rheumatological disease, then pulse steroid therapy or immunosuppressants, cyclophosphamide, that you have to think about. Immunosuppression, the main main modality for treating HLH is your steroids, and in steroids, dexamethasone is preferred, especially when the CNS involvement, because the brain penetration of dexamethasone is much better. Any patient should get 10 milligram per meter square body surface area, which corresponds to around 50 to 200 mg per day. So you can maybe give them according to weight 8 mg BD, or even more than that, up to 20 mg per day you can give. And if they are not receiving any other immunosuppressants and only steroid therapy, you can go up to 40 mg per day, such a high dose of a dexamethasone. Secondary HLH, consider other according to whether etiology, like if there is an infection, then anakinra, which is interleukin 1 antagonist, or maybe rheumatological disorders, then also anakinra will help along with steroids. And ruxolitinib, jack kinase inhibitors, especially when there is a malignancy or EBV related HLH. Cyclosporine, tacrolimus, the calcineurin inhibitors that you have to use um, in many, maybe graft versus host disease or many other malignancy related HLH. Familial CNS involvement. In those cases, if the patient with HLH presents with CNS involvement, then etoposide based therapy should be started much early. In Otherwise, in other etiologies or other cases, etoposide is the salvage therapy. When other your primary or secondary agents, when they are not working, you are starting etoposide. But if your patient is having CNS involvement, if patient is having encephalopathy or seizures, focal neurodeficit, and you are suspecting HLH, start etoposide early. uh, Again, when you are giving treatment, you need to track the response, how long to give such treatment. There are no particular guidelines how many days we need to continue, but you have to monitor the response. You have to see for the fever curve, ferritin level, C reactive protein value, D dimer fibrinogen level, liver function test, whether bicytopenia is getting better. So accordingly you have to titrate your treatment. uh, so again, the organ dysfunction in the secondary hemophagocytic lymphohistiocytosis or macrophage activation syndrome. Uh, Accordingly, you have to consider the treatment, whether just the steroids or steroid with some other immunosuppressants. So when there is a mild, means there is no any organ dysfunction except the coagulation and hematological problems, like maybe bicytopenia is there, or maybe just fibrinogen is low, but there is no involvement of any other organ, like no ARDS, no CNS involvement, no kidney involvement. Then you have to just treat the underlying trigger. If it's an infection, they treat infection. If it is malignancy, maybe chemotherapy, or autoimmune. Accordingly, you have to just treat the trigger and consider steroids in case of rapid deterioration. You can wait for steroids if there is no organ dysfunction. In moderate cases, when there is a SOFA score of 2 or less, at per organ systems, excluding coagulation and hematological system. Here, maybe CNS is involved, RS is involved, but the SOFA score is 2 or less. Then again, treat the underlying trigger. That is the common for all, mild, moderate, severe. Underlying trigger, you have to, anyways, you have to treat that. If infection, antibacterial, antifungal, whatever, that you need to treat. But then In moderate, you have to strongly consider steroid therapy, and in severe cases, when SOFA score is 3 or more, and at least one organ system apart from your hematological and coagulation, if that is involved, or patient is needing mechanical ventilation, maybe dialysis, high vasopressors, extracorporeal life support, all these are all severe category. In that, you have, along with glucocorticoids, you have to add other additional immunomodulatory or immunosuppressants like etoposide, or maybe if it is rheumatological condition, then cyclophosphamide, otherwise anakinra. Proposed response to therapy. So when patients improve, there is an improvement in ferritin or normalization of temperature, a clinical status like organ dysfunction is getting better after starting within 2 to 3 days of starting the therapy, then you call it as a patient is responsive. Then continue full treatment of the trigger, reassess daily disease condition, and wean the therapy, whatever steroids or immunosuppressants you are giving, as per tolerance you can wean if patient is responding. If the patient is not responding, means there is no improvement in the ferritin levels, they are persistently high, their fever is persistent, there despite 2 to 3 days of your steroid or immunosuppressants, then reevaluate the triggers, whether it is some other cause also causing HLH, and consider adding additional HLH director therapy. And progression means ferritin is going high despite therapy, organ dysfunction is worsening. Maybe initially the patient was on NIV, now got intubated. So when there is a progression, then you have to highly consider addition of the other uh, immunosuppressants apart from steroids. And recommended therapy here, though it's very uh, uh, di- uh, it looks difficult to understand, but once you go through treatment of secondary HL, it's very easy. There are only 3 4 drugs, and you have to just remember in autoimmunological conditions, in infectious conditions, and this malignancy related, what immunosuppressant to use. There are only 5 drugs, so it becomes very easier. So secondary HLH, mild, moderate, severe. Dexamethasone, I have already told. You can use up to 20 mg per day. When you are using alone in mild cases, then you can go up to 40 mg per day. But again, these doses, there are not like guidelines. They have not mentioned the fixed dose. There are various RCTs and observational studies. So through that, they have concluded you can use this much of a dose. Um, but they have mentioned 10 mg per body meter square of a body surface area, uh, or equivalent dose of methylprednisolone. But then again, CNS involvement, better to use Dexa. Consider addition of anakinra when it is moderate degree. Then apart from steroid, you have to add anakinra, especially when infections or rheumatological disorders is there. Again, they mention the dose. And severe cases, CNS involvement, then you have to add the etoposide. But again, etoposide has its own side effects, so you have to consider the dose according to kidney function and age of the patient, and you need to taper the dose weekly. Macrophage activation syndrome, again in that mild, moderate, severe category. In mild category, just the pulse steroid with maximum 1 gram per day of a dose for 3 to 5 days, plus or minus IVIG you can think of. When it is autoimmune disorders, rheumatoid arthritis and all rheumatological disorders, then you can think of IVIG as well. In moderate diseases, again anakinra you have to add, or you can think about tocilizumab, um, and cyclosporine as well. In severe cases, etoposide and cyclophosphamide. Malignancy associated, again etoposide, steroids, and IVIG. Once stabilize, once patient gets little better, then start chemotherapy. Additional therapies like IVIG, plasmapheresis, cytokine adsorption. Again, not very proven, but they have anti-inflammatory role, so it can be used. Salvage therapies like tocilizumab, ruxolitinib, alemtuzumab. Again, these are like salvage therapies. When nothing is working out and there is a refractory HLH, you can try these additional therapies. Again, I've already mentioned steroid is the mainstay of the therapy, and DEXA has a CN, good superior penetration. Relative contraindication is uncontrolled infection, but we know that infection with septic shock can lead to HLH. So don't withhold steroids. Maybe use not the high dose but the moderate dose, but you have to anyways give it. When you are suspecting lymphoma, many times diagnosis become difficult when patient is on steroids. So before starting steroid infection, better to do tissue sampling when you are suspecting lymphoma. There is some neck swelling, lymph node swelling. It's better to do imaging and tissue sampling before starting steroid. And as I've already mentioned, 15 to 20 mg per day. Maximum you can give 40 mg per day. Fulminant HLH, combine moderate dose steroid with other immunosuppressants like anakinra and ruxolitinib, and again pulse steroid in autoimmune disorders. But again, when you are using pulse steroid, you have to be cautious about invasive fungal infections like aspergillosis. Interleukin 1 antagonism is anakinra. It's a second line agent following steroid treatment, and it doesn't interfere with your malignancy workup like steroid. It causes immunomodulation without significant immunosuppression. So it doesn't cause significant immunosuppression. That's why in infective etiologies it is preferred. Now, infection related HLH with organ dysfunction, it has a mortality benefit according to few RCTs. HLH due to rheumatological disease, you can use this at a high dose. It can be given subcut or IV. Again, the disadvantage being you have to adjust dose in renal failure and cost and availability. Janus kinase inhibitor like ruxolitinib, because it acts on multiple signaling pathway. Um, you can use it in steroid refractory cases, steroid refractory graft versus host disease. Adverse effect again, cytopenias, hepatotoxicity, drug interaction that you have to consider. So in that Janus kinase inhibition, you have two drugs, ruxolitinib and baricitinib. So just you need to know which one is metabolized by liver and which one by kidney. So if you have a kidney dysfunction, you can use ruxolitinib. When you have a liver dysfunction, you can use baricitinib. Calcineurin inhibitors like cyclosporin, tacrolimus. Again, uh, it helps. They are like a steroid sparing agents. Like in our transplant patients also, as a to reduce. Once we add these agents, we don't need a very high dose of steroids. So it avoids massive steroid doses. It has a rapid onset. Again, side effects the same like neurotoxicity. In neurotoxicity, you have this posterior reversible encephalopathy syndrome, which is very typical of cyclosporin inhibitors, calcineurin inhibitors, especially cyclosporin, and even with tacrolimus. They have the narrow therapeutic windows, so you have to monitor serum level of cyclosporin or tacrolimus. Indications: HLH due to mass, again rheumatological disorder related HLH, drug induced HLH, and refractory HLH. Again, dosages they have mentioned. And last drug is etoposide. Again, familial HLH, which is a uh, poor prognostic form of HLH, severe EBV related HLH, and whenever neurological involvement and refractory. In all these cases, you use etoposide. Again, etoposide has a myelosuppression and secondary leukemia as a side effect. So this was about HLH. In HLH, just you need to know it's a mimicker of septic shock. Dengue hemorrhagic shock can present like HLH, or maybe it is associated with dengue hemorrhagic shock syndrome. Then you need to know various etiologies and apart from steroids, what other immunosuppressants that you are giving, the diagnostic criteria, uh, out, what is this like importance of ferritin level and all. So per se it's not a very difficult topic. You need to know uh, some few important points, and if you'll read, you will come to know which immunosuppressants is better for malignancy and which for autoimmune disorders. Now the second case is 72-year-old male, known diabetic hypertension, ISD, CA prostate, obstructive uropathy, baseline creatinine of 2 milligram per dl, non-oligouric, got admitted for first cycle of a chemotherapy. He developed sinus. I have not mentioned this cancer. He had the diffuse large B cell lymphoma, and he got admitted for chemotherapy. uh, develop sinus bradycardia, drop in blood pressure, ECG done, suggestive of following pattern. I mean, again, ECG, you consider here ECG showing sine wave pattern, or maybe there is a broad QRS, prolonged PR interval, prolonged, I mean, hyperacute T wave like pattern. So when there is a sinus bradycardia, ECG showing broad QRS, prolonged PR, nearly a sine wave, it indicates what electrolyte abnormality? I have not put the picture actually, like ECG. ECG is showing sinus bradycardia, prolonged PR, maybe heart blocks, sine wave patterns, hyperacute tall T waves. Anybody? Patient of diffuse large B cell lymphoma. So he has a CA prostate as well, uh, and he has kidney involvement because of that CA prostate, which got resolved, and now he is there for diffuse large B cell lymphoma treatment, and his ECG is showing all these changes. Commonest possibility, which electrolyte abnormality can cause sine wave pattern and bradycardia with patient with deranged RFTs? Anybody?
Two false. Two here false.
No, no, no. I mean, which electrolyte abnormality can produce ECG changes of sinus bradycardia, or maybe heart blocks or sine wave pattern?
Hyperkalemia will affect
Yes,
الأفينول.
yes, yes. I'm sorry, I did not put. I thought maybe I've inserted ECG in that, but
Uh-huh.
yes, these changes indicate hyperkalemia. So, malignancy, underlying maybe large diffuse, even CA prostate can.
Hemolysis syndrome.
Yes, yes, very good. All so suggestive of all these pattern, all including all electrolytes, uric acid and LDH was sent, and all of the following is true except tumor lysis syndrome is common with leukemia, lymphoma,
Yeah.
more with these than the solid organ tumors. Keep high threshold for hemodialysis in such cases.
No,
Rasburicase should be given as a prophylaxis or a treatment at uric acid level more than 8 milligram
هذا
per.
should be ممكن. Yeah,
IV,
true,
IV hydration with saline should be started,
true,
and all 4 hourly all electrolytes, uric acid, LDH needs to be done.
true also.
So which statement is false here?
Two.
Yes, you have to have a low threshold for hemodialysis. So risk factors for tumor lysis syndrome. So whenever you are using initial induction agent, induction therapy, uh, or those with the high disease bulk, like large diffuse large B cell lymphoma, or those with the high baseline LDH level, high WBC count, even leukostasis. If patient is having AML, CLL, and patient's WBC blast cells are high, even they are at a high risk of developing tumor lysis. Certain solid organ tumors, like in this case CA prostate, even they can produce as a once they start chemotherapy, they can develop TLS. But like some lymphomas and diffuse large B cell lymphomas and Hodgkin's lymphoma, even before starting chemotherapy, because of the tumor burden, they can have tumor lysis syndrome, spontaneous tumor lysis syndrome. So, especially the bulky tumors with the more than 10 centimeter diameter, and when there is a infiltration of marrow, spleen, liver, metastasis, then also they produced as a TLS. Potential for cell lysis is novel or more potent therapies. More potent cyto ablative therapies, more is the chance for tumor lysis. Highly chemosensitive tumors like CA prostates are highly chemosensitive. High those who are rapidly steroid responsive tumors, or those who are radiotherapy responsive tumors, they all can present like this. So or before the treatment, if patient is having underlying AKI, Like in our case, because of CA prostate, he is already having some obstructive uropathy and AKI. Hyperuricemia, because of the underlying kidney condition or maybe gout. Hyperphosphatemia, hyperkalemia, underlying nephrotoxins. Maybe patient is on NSAIDs or some immunosuppressants which are nephrotoxic. Cardiac insufficiency, maybe patient is having heart failure, IHD status, older age, obstructive uropathy. All these are the risk factors to develop TLS. So whenever such high tumor burden patients come for a chemotherapy and they have these underlying factors, you have to suspect they may land up into tumor lysis syndrome, and you have to, before starting chemotherapy, you have to maybe start hydration prophylactically to these patients. And when very at a high risk, like maybe bulky tumor more than 10 centimeter, LDH level is high, it's better to shift such patients in ICU and start chemotherapy there. So malignancies with a high risk of TLS, you need to monitor calcium, magnesium, phosphate, potassium, creatinine, uric acid, and LDH. When it is a low risk tumor, you can do all these labs daily once, but high intermediate risk at least twice. In and high risk, like in our case, you have to do it every 4 hourly. Screen for G6PD deficiency if your uric acid is more than 8, because if more than 8, you have to start rasburicase, which is a urate oxidase. Uh, this drug cause, if used in G6PD deficiency, cause methemoglobinemia. So you have to screen for G6PD before starting this drug. Avoid hypoperfusion to the kidneys and nephrotoxic agents, because already there is a high chance that patient will develop TLS and AKI. So anything that can precipitate AKI, you have to avoid. Again, this is a very busy slide, but again, leukemias is the commonest. It is showing high, intermediate, and low risk conditions. So the extreme right is showing there are two tables, and in both the tables, extreme right shows the high risk. In high risk, you have Burkitt's lymphomas, leukemias, AML. uh, Again, you have CLL, some varieties, CML. So your AML, CML, CLL, Burkitt's lymphoma, large diffuse B cell lymphoma, anaplastic large cell tumors, then mantle cell lymphoma. These all carry high risk of spontaneous tumor lysis syndrome. So even before starting chemotherapy, they may go into that TLS. And others, being plasma cell leukemia, small cell lung cancer, even they are intermediate in certain solid tumors. So again, presentation, many a times, like in our case, hyperkalemia related arrhythmias or ECG changes, and but again, it's a potassium beyond 6.5. It's a very high risk of sudden cardiac arrest. So you have to aggressively treat it. Start your hydration, but the first priority is treating hyperkalemia. Then hypocalcemia related paresthesias, muscle spasms, tetany, seizures, and delirium. Unless and until patient have hypocalcemia symptoms, don't treat hypocalcemia, because here hypocalcemia is because of hyperphosphatemia. Because phosphate is so high, it binds to calcium and it forms the calcium phosphate crystal, and that's why calcium goes low. If you supplement them with calcium, more and more phosphate will bind to calcium, more crystals will be formed, it will obstruct your renal tubules and it will worsen your AKI. Again, if AKI is worsened and output drops, these potassium and calcium, magnesium, which is elevated, it will not go out of the body. So the main here, the problem is because of uric acid and because of phosphate, crystals are formed which block the tubules, and that causes AKI. And if urine output drops, so we don't want this crystal to get precipitated in the tubules and block the tubules. So we hydrate these patients very aggressively if there are no active contraindications. Maybe patient is not having volume overload signs, cardiorespiratory failure, and all. But in that also, you have to start hydration, maybe at a lower rate, but keep urine output 100, at least more than 100 ml per hour. Hyperuricemia related oliguric renal failure, gout, as they can present like that. Hyperphosphatemia, again I've told you, calcium phosphate crystal precipitation. When phosphate is quite high, it can cause muscle weakness, and patient might have some breathing difficulty, might need ventilator. A patient can present as a AKI and volume overload. So, to diagnose tumor lysis syndrome, there is this Cairo Bishop criteria for clinical and lab tumor lysis syndrome. Two or more of the following criteria, either 3 days prior to or 7 days after chemotherapy. Even after 3 days prior to chemotherapy, they might develop this. That's why prophylactically you have to give allopurinol or rasburicase according to your uric acid level to these patients. Prophylactically, you have to start hydration. Prophylactically, you have to start allopurinol or this thing if they are a high risk tumor lysis syndrome, and they present with two this following criteria: uric acid level more than equal to 8 milligram per dl or more than 25% rise from the baseline, potassium more than 6 milli equivalent per liter or 25% increase from the baseline, phosphorus more than equal to 6.5 milligram per dl, calcium less than 7 milligram per dl or less than or 25% decrease from the baseline. So of these, at least two criteria, two or more should be present of the four. These are the lab criteria. And what is the clinical criteria? Lab tumor lysis, ये lab criteria plus one or more of the clinical criteria. So out of three, at least one or more clinical. So creatinine more than 1.5 times the upper limit of the age adjusted range. Cardiac dysarrhythmias, like in our case, patient had ECG changes, arrhythmias, or sudden death, and seizures. In any one of this, any one of the clinical or two or more of the lab criteria when fulfilled, then we can label it as tumor lysis syndrome. Again, you have differentials for this case. They also present as sepsis, septic shock with mods, maybe urosepsis related shock and mods, ALF, ACLF, tissue necrosis because of rhabdomyolysis, hemolysis, crush injury, hepatic acute hepatic necrosis, pseudo hyperkalemia due to high WBC or platelet count. Maybe because this AML, ALL, if they have high blast count, leukostasis, they will have a falsely high WBC count, potassium. So you might think it is a part of TLS. So renal failure of any etiology. So prophylactic management. TLS occurs 12 to 72 hours, 72 hours after initiation of chemotherapy. Most of the times it is. That's why one day prior to starting chemotherapy in a very high mass tumor or a high risk tumor, you shift patient to ICU, or at least before 12 hours before starting chemotherapy, because after within 12 hours patient may develop TLS once chemotherapy agent is started, or sometimes spontaneously in high burden tumors like Burkitt's lymphoma or after radiotherapy. IV hydration for intermediate and high risk cases, give at least 2 to 3 liter per day, one day prior to chemotherapy till its completion, targeting output more than 100 ml per hour. That should be the hydration plan. Be cautious of volume overload if present with low urine output. In such cases, you can give loop diuretics. If you are finding some volume overload sign on 2D echo, or maybe now patient is getting tachypnea, creps are there. Patient is retaining fluid due to cardiorenal dysfunction, low EF, congestive liver, then you have to reduce or stop the fluids. Balanced salt solution preferred. But again, if patient is presenting with high potassium, then don't use balanced salt, use NS. So depending upon pH, depending upon electrolytes, you have to choose the fluid. If patient has ABG showing nagma, normal and hyperchloremic metabolic acidosis, then you have to use the isotonic bicarb. Even bicarb is not preferred much here. Urine alkalinization is not the concept nowadays we use in tumor lysis syndrome. Why? Because alkalinization itself can precipitate calcium phosphate crystals, and main our worry is urate crystals and calcium phosphate crystals blocking the tubules, and then your potassium phosphate will not go out of the body, and patient will invariably need dialysis. So anything that precipitate these crystals, you have to avoid that. So don't correct calcium if patient is not symptomatic. Don't alkalinize urine. You can give isotonic bicarb if there is a nagma in blood gas. You How you prepare isotonic bicarb? Anybody? Generally in our ICUs, we if your isotonic bicarb, whatever soda bicarb we are using is hypertonic. It's very hyperosmolar, hypertonic. So for to make it isotonic, in D5 460 ml, you add 40 ml of a soda bicarb. Sorry, D5 425 ml, you add 75 ml of a soda bicarb and you make it isotonic. If you are using D5, which is as good as the free water. So if you are making it in D5, you have to add 75 ml of a soda bicarb. If you are making it in point ns 9 ns, or RL, uh, like a solution, then you have to add only 40 ml to make it isotonic. But if there is no nagma and all, don't use bicarb. Treat life threatening electrolyte abnormalities, I have already mentioned. uh, Again, we will see which modality of dialysis and why continuous versus intermittent. Uric acid reduction with xanthine oxidase inhibitor like allopurinol. You can use 300 to 600 mg BD of allopurinol, or febuxostat. Those who are allergic to allopurinol, you can use febuxostat. It started 2 to 3 days before starting chemotherapy. So it's not just that uh, once you diagnose TLS, then you are starting. If patient is having high tumor burden, like hydration, you are starting before starting chemotherapy, you can start your allopurinol or febuxostat or rasburicase even before. Uh, but again, you have to look for the side effects. The allopurinol has a hypersensitivity reaction, which is one of the commonest side effects. And even in AKI also, allopurinol dose you need to reduce if patient's creatinine is increasing. Any rash, you have to stop allopurinol. Otherwise, it can cause Steven Johnson syndrome or toxic epidermal necrolysis, DRESS syndrome. So any rash, you have to stop allopurinol and choose raspbericase instead of that, or febuxostat. Again, for raspbericase, G6PD deficiency, you have to rule out. The dose of a raspbericase is 0.2 mg per kg IV. Generally, these medications given for 4 to 5 days. Avoid hyperkalemia because till the time chemotherapy is ongoing. Avoid hyperkalemia, hyperphosphatemia. If potassium containing anything, of course, you have to hold. Especially, you have to hold unless patient is going below 3. So even if patient's potassium is 3.5, don't uh, I mean, you have to hold potassium when patients because of hypokalemia, if patient is taking potassium up to 3, you can continue, but beyond 3, please don't give potassium. Even if you are feeling ki potassium 3 hai, it's less, but patient has a high probability of landing into TLS. Below 3, you can continue syrup Kesol or maybe KCL, but beyond 3, don't give. And sevelamer and all if there is a hyperphosphatemia. So again, hyperphosphatemia, administration of a phosphate binder, initiation of renal replacement therapy, hemodialysis or CRRT, especially, and for hypocalcemia, treating with calcium gluconate is not the solution unless patient is symptomatic, maybe developing tetanus or seizures, perioral numbness. Then only you treat with calcium gluconate, because I've already told it precipitates phosphate. Along with phosphate, it precipitates calcium phosphate crystals and block the tubules. If there is a hypocalcemia, better to get dialysis rather than treating it with calcium, because it indicates the phosphate load is such a high. Now patient is getting severely hypocalcemic because of that. Hyperkalemia, we have already mentioned, moderate to asymptomatic more than equal to 6, severe is more than 7. uh, your routine pentatherapy you have to give, but here you have to remember this: calcium gluconate 1 gram IV slowly push you have to give. If it is a calcium chloride, it is thrice 3 times potent than calcium gluconate, so you have to adjust dose accordingly. And GI drip, soda bicarb try to avoid, and RRT is the last resort. But you have to consider RRT much early. If with one or two medical therapies, if your potassium is not going down, immediately start dialysis. Again, in dialysis, if patients hemodynamics are stable, volumes overload and other things are not very significant, then you start with intermittent hemodialysis for this potassium phosphate to take out early, and then shift or switch to CVVH or CVVHDF. But if patient is already in shock, there is like volume depleted and all, so in such cases you have to start with the CVVHD or CVVHDF if patient is in associated septic shock as well. So because in CVVHD, by keeping dialysate rate high, you can take this potassium and uric acid and urea and other things out quicker. But even if to start with, you have to if the hemodynamics are stable, you are starting intermittent hemodialysis, but you have to switch to continuous venovenous hemodialysis. It's because it's tumorlysis, it's a tumor is going to break down till the chemotherapy is ongoing, and these electrolytes, uric acids, they are gonna increase for the till the time your treatment is ongoing. So your intermittent hemodialysis will take care of for short time, for 4 hours, for 6 hours. Again, in next 4 to 6 hours, your potassium will go up, phosphate will go up. So for such cases, you need that's why for tumor lysis syndrome, you need continuous modalities. But of course, with potassium of 7, it takes some time with CVVHD to work. If hemodynamics are okay, you do intermittent hemodialysis, take that potassium, uric acid, and urea create out in 3 hours, and then switch to CVVHD or CVVHDF. This is the treatment chart. So all these metabolic disturbances, we have already seen the cutoffs. You need to know the cutoffs, like for uric acid more than 8, potassium more than 6, phosphate more than 6.5, calcium more than 7. And if there is no TLS, assess the risk for the TLS. If the risk is low, just adequate hydration you have to maintain in what you treat the patient. If the risk is high, if intermediate risk, then also you can hydrate. Daily allopurinol prophylaxis you have to continue. Consider rasburicase if your uric acid level doesn't drop despite starting allopurinol. But once there are no TLS related electrolyte abnormality, but the risk is high, you know the tumor type and underlying patient's risk factors, maybe old age, cardiac problem, many other things, then you have to shift patient to ICU, IV fluids, rasburicase, monitor your all labs 6 to 8 hourly, um, all of that, or maybe in HD high dependency unit you have to treat. If patient is having these electrolyte abnormalities, then definitely that along with AKI or symptomatic hypocalcemia or cardiac arrhythmias, then it's a clinical TLS. You need ICU management, IV fluids, rasburicase, labs monitoring every 4 hourly. That aggressively you need to carry out. Might need renal replacement. Keep very low threshold to start CRRT. If electrolyte abnormalities is there, but there is no AKI or cardiac arrhythmias or any symptomatic hypocalcemia, like no TLS with high risk, you have to treat with monitoring every 6 to 8 hourly. We have already seen allopurinol is xanthine oxidase inhibitor. Use it when uric acid level is less than 8. When uric acid level is more than 8, choose rasburicase. Again, allopurinol, it decreases uric acid, but it increases xanthine production, because xanthine itself is insoluble and it can precipitate and cause AKI. So that's why rasburicase is better. Because rasburicase converts uric acid into allantoin, which is water soluble, and it is xanthine is not water soluble. But allantoin is completely water soluble. So in such cases, when even after starting allopurinol, your uric acid, you check your daily uric acid level, or every 8 hourly, whatever you are checking, and if your uric acid level is not dropping, then you have to switch to rasburicase. Again, I have already mentioned, you have to allopurinol, you have to be very cautious about skin rash, SJ syndrome, 10 dress, vasculitis, GI symptoms, hepatotoxicity, AKI worsening. You have to stop allopurinol in all these cases. uh, Half life is 1 to 2 hours, and when create clearance goes down, its half life increases, so you have to come down on the dose also. Febuxostat 40 to 60 mg per day. Raspberry case with more than 8 milligram per dl. The dose is zero point 0.2 mg per kg for 5 days. Or you can give fixed dose of 3 mg and repeat if uric acid levels are still on a higher side. Even after 12 hours, you can increase the dose. Again, side effect anaphylaxis with hemoglobinemia, hemolysis. Get your G6PD levels before starting raspberry case. And one more thing, when you are using raspberry case, uric acid level becomes spuriously low because it start degrading uric acid very fast. So whenever patient is on raspberry case and you have drawn the sample for uric acid, you have to send that sample on an ice bag, so that ice pack, so that this degradation and the falsely low values won't be a problem. Again, I've already mentioned urine alkalinization is no longer recommended, as it decreases uric acid. Uh, uh, because we used to think making urine alkaline, um, it's kind like alkaline diuresis. You can flush out all the uh, whatever the toxins and urea and all. But alkaline environment precipitates uric acid as well as calcium phosphate crystals, and it will worsen the situation. Achieve euvolemia, balance crystalloids, isotonic bicarbonate phenomena. This is now treatment part. For prophylaxis also, hydration and uric acid lowering agent is needed. And now this is the treatment part. For treatment also, you are achieving euvolemia. Once euvolemia is achieved, then you have to continue fluids at a 150 to 200 ml per hour rate till your output is 100 ml per hour, according to the output. If volume overload or uric patient despite adequate volume, then loop diuretics needs to be started. And that hydration and diuretics, it helps to remove potassium as well. So this method will take care of potassium as well. Lower threshold for dialysis initiation. So if with once or twice every 4 hourly you are doing levels of potassium uric acid, but maybe in 8 hours the levels are still high or they are increasing, go for dialysis. CRRT, CVVHD for promoting ongoing removal of a tumor lysis byproducts is ideal. See, if patient is having septic shock as well, then not only hemodialysis, you need to go for convective clearance, hemofiltration. Maybe you are using Auxiliary filters also, because all the endotoxin and all that also you need to take out. So in CVVHD, it's a diffusion process, and CVVHDF, it is diffusion plus convection. So you have to choose either CVVHD or CVVHDF, and not just the CVVH, because diffusion principle is needed for your potassium, phosphate, uric acid, everything, all these small solutes to get cleared efficiently. Ideal treatment for symptomatic hypocalcemia is dialysis to remove the phosphate rather than treating it with calcium gluconate. I've already mentioned early versus late. Here, till now, for intermittent hemodialysis, we are saying late is better because it reduces the chances of patient going into on dialysis, as well as the complications related to lines and so on and so forth. But there are certain situations where early is preferred, like in cases of tumor lysis syndrome, in cases of rhabdomyolysis, early the better. And again, CRRT is better because it's an ongoing process, so it removes the things in a continuous manner. But if there is acute situation like severe hyperkalemia, refractory volume overload, and patient's hemodynamics are okay, you start with hemodialysis and then switch to CVVHD or sorry, this is not CVVH, CVVHD or CVVHDF. There should be D. Dialysis diffusion we need. Uh, Indications again same as any other dialysis indication: refractory volume overload, severe oligoanuria, refractory hyperkalemia, uremia, calcium phosphate products if you are measuring that if it's more than 70, and symptomatic hypocalcemia. So this is the end of today's. I've just covered two cases, HLH and tumor lysis syndrome. Both are very important EDIC point of view. At least in your EDIC 2 as well as in EDIC 1, you'll have some questions on these two. And in hematology, I have not covered two more topics: leukostasis and this hyperviscosity syndrome. But these are like oncological emergencies. Mostly when there are blast cells are quite high, uh, you get this. Or in case of multiple myeloma, plasma cell dyscrasias, or Waldenström macroglobulinemia, all these cancer situations where plasmapheresis or opheresis is important. Just read about it. You need to know the presentation, how viscosity blocks the small vessels, and presentation wise how patient presents like with hypoxemia or CNS symptoms. uh, so but that will be a part of oncology. That's why I've not covered it. I've not put questions, but I will prepare some questions and I will forward it to Farz Academy, and then you can solve the questions, because these two topics, they are very important. You need to you need to just know certain few points, because beyond this they will not ask in the exam. So these are like scoring topics. Thank you.